Well, I'm Dr. Kevin Kavanagh from Health Watch USA, as most of you know. And I'd like to talk to you this afternoon about hospital-associated infections and the prevention of methicillin-resistant Staph aureus. Now, healthcare-associated infections is a huge problem. It affects 1 in 25 hospitalized patients. And it's been listed as one of the top 10 leading causes of death in the United States. And this is the equivalent to the crashing of one Boeing 767 every day. Many of these infections are multi-resistant drug organisms. According to the CDDEP, 20% of healthcare-associated infections are MDROs, or multi-resistant drug organisms. And it is known that infections from MDROs have twice the mortality rate of that of resistant or of non-resistant organisms. In other words, organisms that cause healthcare-associated infections but are not resistant to antibiotics. And unfortunately, the percentage of MDROs is increasing. Now, a lot of people ask, how are we doing with infections? And how are we doing with controlling of MRSA? Well, the answer is we really do not have a definitive answer. We do not have a uniform survey system or a uniform reporting system that looks at all aspects and all patients. This slide has different reporting systems that have captured different snapshots of how we're doing. Those from HCUP data, the University Healthcare Consortium, the National Healthcare Safety Network, and a survey of pediatric ICUs all indicated that we may not be doing as well as what we had thought. In fact, they've indicated little improvement. Another, the Emerging Infection Disease Program has indicated that there is a reduction in MRSA, with hospital onset being decreased by 46%. The EIP program surveys hospitals in 9 metropolitan areas. So it's not comprehensive. And all of these programs just take a snapshot. They look at one segment of our population rather than a comprehensive reporting system. Now, if you want to know how we're doing with the rest of the world, the answer is not good. According to the CDDEP, the United States has the 3rd highest percentage of Staph aureus cultures, which is resistant to methicillin, or MRSA. Only Malta and Portugal beats us. The percentage of our cultures that are methicillin resistant is approximately 50%. Within the United States, Kentucky resides in the region that has the highest percentage of methicillin resistance. 70% of our staph cultures are resistant to methicillin or MRSA. And this compares to Northern Europe, where many of those countries have well under 5% resistance. Now, we have a new reporting system to the National Healthcare Safety Network for bloodstream infections from MRSA. And this is very important. It's going to be a uniform reporting system, but it doesn't capture all infections. The severe infection shown on this screen, for example, is a soft tissue infection, not affecting the bloodstream, and it would thus not be reportable. But nevertheless, the data is out. We've had 9 months of data. And if you look at this, unfortunately, Kentucky has the 4th highest rate of methicillin-resistant bloodstream infections in the United States. And this is of the 50 states. So this verifies the CDDEP data that the United States has a problem, and indeed Kentucky is in the area where the problem is even worse. Now, Health Watch USA feels strongly that surveillance is being underutilized. To paraphrase the Union of Concerned Scientists, we feel that it's an example of the downplaying of evidence in the upplaying of false uncertainty. There have been 2 major studies with arguably poor designs which have been used to undermine the recommendations for surveillance. They're the STAR ICU study and the study which we'll refer to as the JAMA Swiss. In the STAR ICU study, it took 5 days before admission culture results were known. And in the JAMA Swiss study, well over 50% of the patients that were known to be MRSA positive prior to surgery did not receive antibiotics effective against MRSA. And these are the two studies that have been used to form our policies. Now this compares to numerous before and after studies, approximately 40, plus a number of well-controlled studies which have shown surveillance to be beneficial. This is a table of our current studies regarding this subject. In the upper left-hand are the 3 studies which are well-controlled that have shown surveillance to be beneficial. Down below are 40-plus studies that are before and after studies, including the very large study for the VA, which has shown surveillance to work. The upper right-hand corner are the 2 studies by Harberth and Huskins, published in major journals, but with, I feel, major flaws in implementation that have been used even at a congressional hearing to prevent recommendations of being formulated. And finally, in the bottom right-hand side, the study by Huang, which is now advocating the use of chlorhexidine on every patient every day in the ICU. And we'll quickly go through these studies. The first one was from Northwestern, published in 2008, used a combination of surveillance, decolonization, and contact isolation. Very similar to the VA findings, they observed a 70% decrease in MRSA infections with universal hospital-wide surveillance. Rodriguez-Bagno published a really interestingly controlled study looking at the rates of MRSA, Methicillin-Resistant Staph aureus, to methicillin-sensitive Staph aureus, and they just intervened in the MRSA group by having a surveillance and decolonization. They did nothing with the methicillin-sensitive. That was their control group. And as you can see, there was a significant reduction in the MRSA group compared to the control. Lee et al. Published in the British Medical Journal their results of preoperative screening on preoperative patients. And their conclusion was, this was a well-controlled study, by the way, their conclusion was that screening, contact precautions, and decolonization resulted in a significant decrease in infections. And there was no evidence that enhanced hygiene alone was effective. It is by far the most important, but by alone, or by itself, it is not effective. You have to do other things. It has to be a bundle. And this is one of his big recommendations, that implementation of single interventions was not effective. I hear all the time, well, screening is always part of a bundle, so we can't tell if it's effective. Well, the answer to that's simple. Screening is not effective. It is not an intervention. It identifies those patients that you intervene with. So it always has to be combined with something else. And certainly if you don't even then check the results for 5 days, it's not going to work. The VA experience, 36% decrease in MRSA in nursing homes. Nationally in 2011, it was published a 62% decrease in ICU patients. And a few weeks ago, data was released nationally that there was a 72% decrease to 0.46 infections per 1,000 patients. That's less than 1 infection in the ICU for every 2,000 patient days. Excellent results, which are hard to match by other institutions. Now, briefly, we'll go through some of the studies which have found surveillance not to work. The first one was Harberth et al. This was published in JAMA. This was a study that was published alongside, published about a month after the Northwestern study, and it was entered into a congressional hearing. Wasn't referred to by name, but was referred to by results, and used to really undermine any recommendations for performing standards. And in this study, 31% of the carriers were identified only after surgery. Now, there were emergency patients, and surely if you do a test and you don't have the results before your intervention or before your surgery, it's not going to be effective. That goes without saying. Only 43% of patients who were known to be MRSA positive prior to surgery were given antibiotics that were effective against MRSA. And most disturbingly, there were 10 MRSA carriers known prior to surgery that did not receive effective MRSA prophylaxis that then developed an MRSA infection. This study was published in JAMA and then has been used to formulate our healthcare policy. Another study by Huskins et al. Was published in the same issue that published the VA study, and again was quoted on a governmental blog as being a reason why we can't formulate any recommendations regarding surveillance. This study had very poor contact precaution compliance, with 69% of staff having a proper hand hygiene, but more importantly, it took 5 days to get back the MRSA culture results. They sent them to a lab in Atlanta, and so these were admission cultures, and of course by that time I would suspect these patients may have been contaminating the hospital. Now the latest study is by Huang et al. And has to do with chlorhexidine. And chlorhexidine is a very complicated subject. There are a lot of nuances to it. And it's essentially, we're going to treat everybody the same rather than identifying these categories or individual patients that need to be treated. And with chlorhexidine, it's advocated that every patient, every day in the ICU is bathed with chlorhexidine. The study that is most often quoted is Huang et al. And this study, which disturbed us greatly, had what we consider major changes in the metrics or the measures in the study that were recorded on clinicaltrials.gov after trial completion date. So this is similar to taking a test and then changing the questions that you want to answer and adding in other ones that you would like to answer. And that causes great concern. Now, we did publish our concerns, and this was answered by the office, by the authors that these changes occurred before trial completion, and we responded that any change after trial initiation shouldn't be accepted. The study did find that there was a significant decrease in MRSA clinical cultures, but MRSA bacteremia did not reach significance. And the largest, most impressive change was in the commensal organisms, and this is, for example, Staph epi, which would normally be considered not a very dangerous organism, that it prevented those bloodstream infections. Now that being said, if you're an immunosuppressed patient that has Staph epi in your blood, that's a dangerous situation. So this is not saying this isn't a beneficial finding, but MRSA decreases is, I think, questionable. This is a photo of the changes in clinicaltrials.gov. Now, Dirty et al. In Lancet 2014 published another study looking at improved hand hygiene. So there were two things here, along with daily chlorhexidine bathing. He did observe a decrease in MRSA acquisitions, however not in other types of dangerous bacteria. But something that disturbed me was he also observed a 13 to 14% incidence of resistance to chlorhexidine. Now, the effectiveness of chlorhexidine has also been brought to question by a study in the New England Journal of Medicine in 2013 comparing to chlorhexidine bathing with chlorhexidine washcloths versus non-antimicrobial washcloths, and really had similar findings that MRSA decrease in infections wasn't that significant. The largest decrease was in bloodstream infections, was for coagulase negative staph, but there was an overall decrease in central line associated bloodstream infections and in multi-resistant drug organisms. Again, this is beneficial, but it's still questionably whether or not it's going to have the impact that you want with MRSA. Now, some of the concern with chlorhexidine really goes back as far as 1988 by Rotter et al., who did a classic study looking at chlorhexidine versus bathing with a detergent. This was preoperatively, and found no difference in infection rates. And recently, a review of the subject by Mawald and Chan found no evidence that chlorhexidine without alcohol was effective In other words, many trials were comparing 2 agents to 1 agent, and a few of these would then advocate using chlorhexidine alone. We've discussed bacterial resistance. Edgeworth et al. Has discussed this and the genetic basis of it with MRSA, how MRSA bacteria can become resistant or have reduced susceptibility to chlorhexidine. And chlorhexidine resistance has been implicated in both central line infections and in the failure of MRSA decolonization to chlorhexidine. One researcher has even implicated chlorhexidine resistance to fueling the emergence of this extremely drug-resistant strain of Klebsiella. One of the concepts that I think is important is that when you expose the outside of the body to an antimicrobial agent, you're really exposing all the bacteria in the facility or the facility's microbiome to these bacteria. You're just not exposing the targeted organism. So you may have a lot of different changes in a lot of different bacteria, not just MRSA. Studies will advocate that you need to track resistance, that we didn't observe resistance during the study. Well, unfortunately, tracking resistance may be out of the capabilities of many small or rural hospitals, and the observance of resistance, according to the CDDEP, may take 10 to 15 years to develop. And once it develops, it's very hard to get rid of. Now, another big question regarding chlorhexidine has to do with research integrity and industrial influence. There was a $40 million Department of Justice settlement with CareFusion, which is the maker of a chlorhexidine alcohol product. This evolved around a New England Journal of Medicine study that compared chlorhexidine plus alcohol to iodine alone. It also involved an alleged $11 million kickback, and there's also been allegations of influence of recommendations and protocols from NQF surrounding this. And this is also, I think, a very disturbing finding involving chlorhexidine and some of the recommendations that have come out. Now, the last topic I want to touch on is preoperative MRSA surveillance. And this is really a special category. Now, if you can recall, I discussed about Harborth et al. From JAMA that found surveillance didn't work, but that was a seriously flawed study. Another study by Lee et al., published in the British Medical Journal, was a large, multinational, multi-institutional study which found surveillance to be effective, very well controlled. And Harborth, the author of the previous study, was the corresponding author of this study. And so, in my view, this study pretty much negates that first study that was used to actually derail our recommendations. Multiple other studies have also been published, which have found surveillance and preoperative studies to be effective, but they were before and after studies. Now, you'll hear a lot of times, well, they didn't control for secular trends, and you think that that's bad. It just means there were before and after study. There might have been some other unknown factor that caused the result. But when you have so many studies that are lining up in the same direction, the likelihood of that gets smaller and smaller, let alone you also have some well-controlled studies. Why do you want to do preoperative surveillance? Well, number one is MRSA carriers are known to have a much higher risk of developing an MRSA infection after surgery. Screening will also determine the length of preoperative decolonization, whether it's 1 or 2 or versus a full decolonization protocol being 5 days. But most importantly, it will determine the type of antibiotic used. If you're giving preoperative antibiotics and the patient is a known MRSA carrier, you'll want to use vancomycin. If not, you'll probably want to use a cephalosporin. There's been at least one article by Dr. I believe it is Gupta, who showed that if you give MRSA negative patients vancomycin, you may actually have a higher infection rate because it doesn't necessarily cover other organisms as well. So I think it is very important to do MRSA preoperative screening. And there's 2 other factors. One is you don't have to do a rapid test if it's an elective case. You can do a standard culture, which is $10 instead of $50. The second is that actually these patients are isolated from the hospital, and they will undergo decolonization and then come back in at a later time when they're cleared. And so that this is, should be a very effective way of taking care of a patient without, producing a lot of the drawbacks that you hear about of isolation. Now, what is done in other nations? And we have a lot of data from the United Kingdom. And they isolate and screen all high-risk patients. Or isolate, of course, if you're positive, I should say. So the United Kingdom, the National Healthcare Service, has a screening program for MRSA of all high-risk patients. And this is a list of all patients they consider to be high-risk. Orthopedic, thoracic surgery, neurosurgical patients, critical care admissions, all emergency admissions, all elective surgeries, and the list is just extensive. And one of the statements that their recommendations make is that the logical conclusion is that you should just do universal screening. Now, the universal screening is a recommendation. The other screening is actually a requirement for the high risk. And if you're from the United States, and you wonder, well, should we adopt those recommendations? The thing you have to realize, if you were to go and be hospitalized from the United States, let's say in a hospital in the Netherlands, according to my infectious disease contacts up there, you would be considered high risk for MRSA just being from the United States. And look at the stats that I gave you from the graphs in the beginning of the talk, and you can understand why. So almost everybody here is high risk. So when you say that the one size doesn't fit all philosophy, really, when it comes to MRSA, we're pretty much in a situation now where we're all high risk. And certainly, the one-size-fits-all philosophy does not work very well for many dangerous pathogens. I think the biggest example we've had of that is Ebola, where we really do need to have firm standards being set. Now, this last slide shows the results of a hospital in the UK which has implemented their mandatory screening, and as you can see, they've had a progressive drop in the MRSA bacteremia that they've recorded, and that graph is really similar to the one that we've just seen from the Louisville VA in the preceding lecture. So I think it is screening. I feel should be mandatory. It's certainly best practice in my view, and it's something I would definitely encourage facilities to be performing. Thank you.